Yeah.
I'm just going to put how to claim credit.
So the slides are not going to be added in because they're just about the QR code. So we don't want to have people try and go to a website that's not working. So, and I've also started recording, so we're now recording. And I'll talk to you guys soon.
That's great.
Thanks, Bill.
As people are joining, I just want to bring your attention to a couple things. If you look in the chats, so if you hit the chat bubble in the upper left-hand corner of the VMR, you'll see that you have the option to send messages down below. In there, I just put in, we're not using the QR code today. To get credit for attending this meeting, you're going to want to email continuinged@hhchealth.org. You have to put your name, email address, and that this was psychiatry rounds today. I'll go over that again in a moment, but just for the people here, you don't want to be looking for a QR code today. There was a problem with our software, and so you're then to email to continuinged@hhchealth.org to get credit for this. So as people are entering, there's a question, is this just audio right now? You should not just see audio. In a few moments, you should see Dr. Montross, and I'm not sure if you don't see me, but you should have, Bill, I don't know if you're there. So we want to make sure that they see the speakers.
We're seeing you right now. I think that's because you're doing most of the talking. So I think when you stop, it should switch to Dr. Montross.
Okay, perfect. Thanks.
You're welcome.
Great. So we have about 50 people in the audience. We'll give it another minute before we get started. Just want to bring everyone's attention back to the chat option, the little bubble in the upper left-hand corner. Two things. Right there, I'm putting the email address to get credit for attending Grand Rounds today. You need to send an email. Do not use the QR code. You want to send an email per the instructions that are there. And we'll get started in a moment. I'll introduce Dr. Montross to you all. While we're waiting for giving people a couple more minutes to come in. For today, we're going to be doing, as it's VMR, when folks have questions, this is an interactive Grand Rounds. When folks have questions, comments, concerns, things that they want to talk about, please feel free to go into that chat option in the upper left-hand corner, put a message in. You could either write your question or comment there, and I'll be happy to facilitate asking Dr. Montross those questions or making those points, or just say you'd like to talk, and I will call on you, when there's a natural break or an opportunity to talk. So either way, just indicate that you want to talk or put your questions there, and I'll help facilitate the conversation. And I keep feeding in the information about how to get CME credit just because there was an issue with our CME software. So you're going to want to email continuinged@hhchealth.org with your name, email, and psychiatry rounds in today's date, 9/10, in order to get credit for attending today. We're up to 83 participants, so we should start in a moment. I'll tell you what, if it's okay, I'll begin the introduction of our today's speaker. And so I'm really excited that Dr. Montross was willing and able to come speak today. Dr. Montross has this really impressive CV, and I'm going to read, I'm going to try to go through this, but there's big words in it. It's hard for me. But we're extremely lucky to have her. Dr. Montross is a 2015 Guggenheim Fellow in Nonfiction, an Associate Professor of Psychiatry and Human Behavior at the Warren Alpert Medical School of Brown University. She's practicing inpatient psychiatrist and performs forensic psychiatric examinations. She completed medical school and residency training at Brown University, where she received the Isaac Ray Award in Psychiatry and the Martin B. Keller Outstanding Brown Psychiatry Resident Award. One interesting thing about Dr. Montross is that she is at least a double threat, and I'm going to go through that in a moment. It's not just a psychiatrist and a forensic psychiatrist, but also a noted author, and that's part of why she's here today. She received her undergraduate degrees in a Master of Fine Arts in Poetry from the University of Michigan, where she also taught writing classes as a lecturer following graduation. She was born and raised in Indianapolis. Dr. Montross's first book, Body of Work, was named an editor's choice by the New York Times and one of the Washington Post's best nonfiction books of 2007. Her second book, Falling into the Fire, was named a New Yorker book to watch out for. Her latest book, Waiting for an Echo, or I guess we have another book after that, was named a New York Times book to watch for, a Times Magazine book to read in July, and an Amazon.com best book of the month. She's also written for many national, including the New York Times, the New England Journal of Medicine, Time Magazine, the Washington Post, Book World, and then also Good Housekeeping and the Oprah Magazine. She's been named a 2017-2018 Faculty Fellow at the Kogut Center for the Humanities, a 2010 McCall Johnson Fellow in Poetry, and the winner of the 2009 Eugene and Marilyn Glick Emerging Indiana Authors Award. She's had several poems published in literary journals, and her manuscript, Imboture, was a finalist for the National Poetry Series. So we're really fortunate to have Dr. Montross here today speaking to us. Just one more time, I'll just give the two pragmatic stipulations. One is that to get credit for attending today's event, you want to send an email to continuing ed at HHC Health. That's in the chat bubble. And then we're going to have an interactive discussion. Dr. Montross will be leading the discussion. And when you do want to speak or engage, you can either send your message in the chat bubble, and I'll let Dr. Montross know, or just say that you'd like to speak, and we'll call on you when there's a break. Without further discussion, and enough for me, here's Dr. Montross. Thank you.
Hello. Thank you so much, Kevin. I really appreciate that introduction. I'm very happy to be with you all, although certainly had hoped to be with you today in Hartford. So thank you for coming. Thank you for joining this virtual event. I always like to take just a minute at the beginning of events like these to make sure that you can hear me loud and clear and that you can see me. And if not, I don't know what to do about it. But I'm sure that there are people here that do. So let somebody know in the chat if there's some kind of urgency on that front. Otherwise, I'll talk with you for a little while here today. I'm really excited to be here. Definitely would like to thank Kevin and the Institute of Living for hosting me here today, and Vanessa and Bill and the folks who helped coordinate this and put all this together. And my hope today, Kevin and I were just talking a little bit, my hope today is for this event to be a little different than usual. I don't have slides today. I like to do my talks a little bit like a literary salon. So I read a little, talk a little, take questions, and really would hope that this would be a discussion. And the topics that we're covering today, Kevin, you were right. This is the most recent book. Waiting for an Echo is the current book that I have written, and it's about the confluence of mental illness in the criminal justice system. So it's a topic that I think is timely, and that I think there's so much for us to discuss together. So my plan for the format of today's talk was to read and talk a little bit myself, and then have comments and questions coming in. We can talk about, I'm happy to take questions kind of throughout and in the middle, then read and talk a little bit again. I'll read a second section from the book, and then we'll do questions and answers again at the end of the hour. So I'm looking forward to this very much and appreciate you having me here. So as Kevin was kind enough to read kind of an exhaustive biography of me, but the salient points really for today are to know that I'm an inpatient psychiatrist. I work at a freestanding psychiatric hospital in Providence, Rhode Island, and it's really a beautiful hospital. It's cut from the cloth of the asylums of yore, in the same way that IOL is. Also, its grounds were designed by the landscape architect who also did Central Park and Golden Gate Park and some really beautiful places. So it feels like a really healing place when you enter. And I work on units called the intensive treatment units, which are the psychiatric versions of the ICU. And these are patients who are very psychotic, very manic, actively trying to hurt themselves or other people. And I love my job and have had it for many years now. But as I continued to work on those units, what I really was surprised to find over the course of my work there was how often my patients came in contact with law enforcement. And what I saw was, first of all, that often the reasons that they came in contact with police often had so much more to do with their symptomatology than any kind of criminal intent. So people were shouting in the Starbucks, or they were charging through TSA, believing that they needed to hop on a plane and get to China, that they had these beliefs that were getting them in trouble in our communities because they didn't align with our societal expectations. So I was noticing that they were coming in contact with law enforcement. I also was noticing that some of my patients would disappear for long periods of time. And of course, that happens. We want them to disappear from the hospital in healthy and productive ways. But often, and those of you who work in inpatient hospital settings know that there is an expectation that we're going to see our patients from time to time. And what I would often find with these most ill patients when they were gone for long periods was that if I would check the Court Connect database in Rhode Island, that pretty frequently I would see that people were spending time in jails and in prisons. So I became really interested thinking about how my patients struggle to maintain behavioral control and comply with rules and regulations in an inpatient hospital setting, and how much more difficult that must be when they're in a correctional or punitive setting like the jails and prisons. So I started really became interested in this question, and my go-to when I become interested in a question that I can't make sense of is to write about it. As Kevin said, that writing books is the way I sort of make sense of the world. So I started performing competency to stand trial evaluations with Kevin and others to really get a look at what was happening when my patients would enter into the legal system. And what I found there, which will likely not surprise you, was that often the patients in the two places where I was working, the jails and the hospital, were really indistinguishable from one another. That if I saw one patient in one place and all the setting had been removed, I would not always be able to identify whether that was a person who belonged in jail or belonged in my hospital unit. And that seemed problematic to me, that the environments were so very different, one punitive, one therapeutic, and yet the people within them were very much the same. So with that as context, I'll read a little bit from the introduction of my book, an anecdote that really, I think, underscores how it is that people come in contact with police and often end up in jail or hospitals based on the moment of the police encounter. So this is from the introduction to Waiting for an Echo. The trajectory of my patients' lives veers sharply when law enforcement is involved. The earliest decision by police as to whether they belong in jail or in the hospital, a decision often made in the moment of the police encounter, may shape the course of the next many years of their lives. As an example, some years ago, I evaluated a man named Henry in the visiting area of a men's jail. Henry was thin and disheveled, and he looked at me with guarded suspicion when the correctional officer brought him into the room where I was already seated. He was wearing a khaki prison jumpsuit with a white T-shirt underneath, and he smelled as if he had not showered in many days. I immediately noticed that Henry's mouth was in constant motion with the involuntary movements of tardive dyskinesia, a rare but permanent side effect that can be caused by long-term use of antipsychotic medications. Henry had been paranoid at the time of his arrest, and his paranoia had not abated in jail. He was refusing to speak to his attorney, prompting the judge to order a competency evaluation. According to the police report, Henry's legal involvement began when he did not leave the premises of a convenience store after the manager instructed him to. Henry hid behind the store's dumpster, refusing to come out when approached by police, and shouting paranoid statements about interrogation tactics and torture and the Connecticut militia. When he finally emerged, Henry was taken to jail. His charges, criminal trespass and resisting arrest, carried a maximum combined sentence of 2 years in prison. But Henry's situation, like that of many psychotic detainees, became far more dire. Henry was prescribed an antipsychotic medication in jail, but refused to take it. He might have been paranoid about the pill's safety, or might not have had insight into the fact that he needed treatment. At some point, shortly after his arrest, he would not come out of his cell when asked to do so. He was then forced out by COs, a procedure called a cell extraction. Still paranoid, but now with no dumpster to hide behind, Henry resisted this time by fighting back. In our nation's correctional facilities, detainees who become assaultive are typically sent to administrative segregation, a punitive form of solitary confinement known to exacerbate symptoms of mental illness. Worse still, assaulting a correctional officer is a felony charge, which in Henry's state carries a maximum sentence of 15 years in prison and a $15,000 penalty. If convicted, Henry would spend years in prison, where mentally ill people face a disproportionate risk of being victimized. He would eventually leave prison on probation, with legal requirements that would be difficult for him to manage if his symptoms returned, setting him up to incur additional time behind bars. Compare Henry's situation to that of Robert, a psychotic man who caused a similar disturbance in the community. Robert, too, was plagued by paranoid delusions. He had come into contact with police while yelling loudly in the streets of his neighborhood that he was an unwitting experimental subject in a secret government program. But unlike Henry, Robert was admitted to my inpatient unit after police decided to bring him to the hospital rather than to jail. Robert was a large, muscular man in his late 50s with a lumbering gait and erratically mussed white hair. He sat on the periphery of the unit and regarded everyone around him with suspicion. Once he was hospitalized, Robert's paranoia became rooted in a fervent belief that the hospital environment was a front and that he was, in fact, being held in a covert government facility where he was awaiting execution. Like Henry, he refused to take prescribed antipsychotic medication. As a result, his paranoid symptoms had improved little since admission. One night, new personnel when a staff member wondered how, in case of an emergency, electronic safety blinds could be activated to cover the wall of windows that separated the kitchen from the rest of the unit. Robert became terrified by the movement of the security blinds and, in the throes of his paranoia, interpreted their closure as a signal. He believed that the unit staff was cordoning off the kitchen in preparation to execute the patients held within. Robert ran out of the kitchen, screaming to the other patients, "Tonight's the night they're going to kill us all." In what he believed was self-defense in a moment of mortal peril, he began attacking the staff. In less than a minute, he assaulted and injured numerous staff members. 2 female mental health workers suffered concussions. One of them hit so hard by Robert that her supervisor later said that she flew off her feet like a rag doll. A male staff member who intervened and tried to subdue Robert was brought to the floor by him, kicked in the head, and eventually required knee surgery for injuries sustained in the altercation. Despite the severity of the attack, none of the injured workers felt that it was appropriate to press charges. They each offered the same explanation. Robert was clearly ill and had been acting out of his illness. He inflicted an enormous amount of damage, but no one perceived him to have done so with malicious intent. As the unit's nursing supervisor said to me in describing Robert's aggression, he was in pure terror. He thought he was fighting for his life. Robert eventually began taking appropriate medications, and his paranoia diminished. After 15 days, he was discharged home with outpatient treatment arranged by the hospital team. Henry, in contrast, remained incarcerated, facing the prospect of spending the next decade and a half of his life in prison. And I want to talk a little bit about those environments, those different environments. So the difference between a therapeutic environment for a patient like that and a punitive environment for a patient like that. And what we see so often is what the former head of Rhode Island prisons described to me as a fundamental misalignment, that when you have severely mentally ill patients in correctional facilities, as we do to such a great degree throughout our country, so much so that the Cook County Jail is our nation's largest psychiatric inpatient facility. When you have so many mentally ill people in our nation's correctional facilities, there's what he called a fundamental misalignment between the expectations that people follow rules, that they comply, and the consequences of those expectations if they're not met. So people are obviously expected in correctional environments to comply. If you are distracted by internal stimuli, if you're hearing voices or seeing visions, if you're extraordinarily paranoid, if you're so depressed that you're catatonic, if you're grandiose and manic, these are all factors of disease pathology and symptomatology that prevent you from complying with the expectations of the facility. The response in our hospitals when people cannot comply with expectations is aggressive targeted treatment. But when people can't comply in correctional facilities, the response is more and more punishment. So what we often see is what one correctional officer described to me as people burying themselves in seg time, meaning accumulating weeks, months, even years of time in solitary confinement, because that's the maximum penalty that someone can accrue, often just from the accumulation of nonviolent charges. To really understand why so many people from our community of mentally ill citizens end up in our nation's jails and prisons, you really have to return to the 1950s, 60s, and 70s with the deinstitutionalization movement. So as many of you well know, in 1963, the Community Mental Health Centers Act was passed, and that intention was really a good one. The intention was to shift people with severe mental illness out of the psychiatric hospitals and into the communities, with the hope that they would leave institutions and lead a more autonomous, free, and humane life in our nation's communities. That was also a good goal because at the time our psychiatric hospitals were relatively inglorious places. Some of them had some pretty draconian practices and records of abuse. So it was an altruistic aim. The problem was that the funds that were promised to the communities to support the mental health treatment of these seriously ill patients never materialized. So suddenly you had people discharged from the state hospitals who required treatment. They had no housing. They often had no food. And so these people wound up, instead of in our institutions, without treatment, without housing, without food, they wound up on streets in urban settings begging for food and money. This is really when the criminalization of mental illness begins. It's a moment that feels familiar, I think, as we are really examining now the role of police in our communities. And as we saw just last week with Daniel Prude, really seeing the consequences of policing and law enforcement being the first line of treatment for psychiatric emergencies. And I think it's really critical that those of us who are in the field of mental health treatment begin to speak out about the illogic of this approach. And I think we are so accustomed to the idea that if there's a psychiatric emergency, the thing to do is to call 911, to have the police show up, to have an ambulance show up, that we forget that this is not the response that we have. A police response is not the response that we have to someone having a hypertensive crisis. This is not the response. We don't send the cops when someone is having a diabetic crisis. We only send police when someone is having a mental health crisis. And the consequences are really severe. Mentally ill people are 16 times more likely to be killed by police than people who are mentally well. So I think that those of us who are in the field and understand how our patients' symptoms can disorient people who are not accustomed to them, how authority figures can escalate those situations, need to begin to speak out about whether or not we believe it's appropriate for the first line of care for psychiatric emergencies to be police, when we could have EMT versions. And I know there are some of these in Connecticut, where we have psychiatric versions of EMTs who show up, who are able and equipped to deal with these kinds of emergencies. All right, it's the Zoomiverse, and I've talked a lot at you all. I have another passage that I will read and will love to discuss, but let's break for a moment right now in case there are questions that have emerged. I'm more than happy to keep talking, but if there are any questions at this point, either about what I've read or some of the issues that I've raised, I'm happy to answer them and have it become a discussion at this moment. Also happy to charge forth. So Kevin, I'll yield to you and you let me know which path we're taking.
Great. And can you hear me okay?
I can, yes.
Great. We have a question in the chat. I think it's from Dr. Shagan, and she asks, have you noticed any difference in police response based on race, or do people with severe mental illness face inappropriate responses regardless?
Yeah, so yes, based on race, there is a different response. And what we know is that race is not only a factor we must consider in the moment of the police encounter, which it certainly is that, but the police encounter we need to really view as the beginning of someone's involvement with law enforcement and the justice system. So what we know is that at every level of the legal system, racial prejudice exists. This is a fact of the world, of our correctional system, that is not, this is data driven, this is not opinion, and I think the only way that we move forward in trying to correct corrections in this regard is to really acknowledge this is a fact of the landscape. I think for me, one of the most potent and powerful elements that contributed to my understanding of this was to look at racial bias in the treatment of juveniles in our legal system. So Black kids are more than twice as likely to be arrested than white kids are. They're less likely to have their cases diverted. So white kids are more likely to have their cases kicked out of the court system initially. Black kids are less likely to have that happen. Black children, less likely to be sentenced to probation instead of jail time, less likely to get community service, and they're more than 4 times as likely to be committed to a detention facility. And there was a landmark ruling, Graham versus Florida. Excuse me, my computer. This is the thing with computers, right? Things start falling off them, and all right, back on the screen. So there was a court ruling, Graham versus Florida in 2010, which essentially said it was unconstitutional to sentence children to life in prison without the possibility of parole. Prior to that decision, which was just 10 years ago, Florida led the nation in sentencing juveniles to life without the possibility of parole. And 84% of the kids who were sentenced to that sentence in Florida were African American. And the population of Florida is less than 14% Black. So we see these racial disparities not only in the earliest stages of law enforcement, but also in the earliest ages of people who are coming into the legal system. There was a beautifully done and crushing experiment out of Stanford that really looked at racial bias in the sentencing of juveniles. They took 700 white subjects, and white subjects were chosen because we're overrepresented in the judiciary and in jury pools and in the legal field. And they gave them identical information about a real Supreme Court case where this was was weighing the constitutionality of life sentences without parole for juveniles. And so they gave them the specific case of this 14-year-old who had committed a number of really egregious crimes. they altered just one word in the descriptions that were given to the two groups of subjects. The subject was either described as a black male with 17 prior juvenile convictions or a white male with 17 prior juvenile convictions. And though the white subjects who read about a black juvenile were significantly more supportive of the idea of life sentences without parole for juveniles, and they were also more apt to attribute adult levels of responsibility to juveniles, so saying that kids should be tried as adults or serve time in adult prisons. So a long answer to your question today, yes, that race infuses every single level of police involvement, and also infuses the police involvement when they're called to situations where they're called to help the mentally ill.
Thank you. And I know I've written down a bunch of questions for you, but I'm going to defer to the audience first. And again, if folks have questions, either please put them in the chat or just indicate you'd like to speak. There's a question for you, Dr. Montross. Are there action steps you would recommend regarding reducing police first response to mental crises?
Yeah, I think we need to reclaim mental health as an issue of healthcare, right? So I think that we're beginning to talk about this, or have been beginning to talk about this in terms of addiction, that addiction has really been under the auspices of law enforcement. And I think there's been a lot of movement and momentum to bring it back under the auspices of healthcare. But I think we don't recognize as often or as vocally how much this is happening just to psychiatrically ill individuals as well. So first and foremost, I think it's important to recognize that cultural shift needs to take place. It's not all the problem of law enforcement either. So cuts to mental health funding have really substantially altered the landscape as well. And probably most poignantly, I heard about this when talking with the former police commander of Portland, Oregon, Sarah Westbrook, who talked about the difficulty that her officers had when they would choose in that moment of the police encounter to take the person to the hospital rather than to jail, only to find that there were not enough psychiatric beds available. And I had a prison psychologist say to me that the prisons have that the jails have an ironclad no refusal policy. So our psychiatric beds may be full, our units may be full, our ERs or hospitals may be full, but the jails are always open to take people. So Commander Westbrook told me a story that really seared this reality into my mind. She talked about how right previously to when I had spoken with her, there was a man who was down at the Portland waterfront, a public area where a lot of people walk and bike and run. And he had a gallon jug filled with fluid on the end of a long chain. And he was swinging the gallon jug above his head and charging at people. People were understandably very scared. They called the police. And Commander Westbrook said that her officers responded, and what she described was more than 2 hours using very little force. They got the man into their car. They drove him to the psychiatric emergency room. And her description was he was discharged before we were even done with our paperwork. He went back to the waterfront, resumed the activity. The police were called again, and this time they took him to jail. And you cannot blame them in that moment. And so the responsibility is not just the responsibility of police. It's also the responsibility of our communities, our legislators, to really provide adequate services for the mentally ill. People speak about the idea in policing of a compassionate arrest, that they talk about how if you see someone who's severely mentally ill, and someone said to me, at least I know that if I take them to jail, they'll have 3 hots and a cot and they'll see a psychiatrist at some point. Again, we would never arrest someone to make sure they got treatment for their cancer. We would never arrest someone to make sure they had treatment for their diabetes. And so the idea that arrest exists as a treatment option for our psychiatrically ill citizens strikes me as really egregious. So maybe there, I'll shift into the next section of the talk, if that's good with you, Kevin, and you hang on to some other good questions that I think are emerging, and then we'll break again for questions after. Does that sound good?
Sounds good. I'll hold them. Thank you.
Okay, great. Okay, so as we were talking about juveniles, I'm going to read a passage about a facility in your home state, and this is the section of the book from whence the title comes, and it's about Manson Youth Institute in Connecticut, which, for those of you who do not know, is a high security prison in Connecticut for 14 to 20-year-old boys. I walked through the hallways of Manson with a CO, a correctional officer, a CO, and 4 other psychiatrists. As I do, I notice that the only white faces I see belong to adults. Me, 3 of the 4 psychiatrists, some of the staff. There's a yellow line painted on the concrete floor that divides the prison hallways in half. One side, the one that I walk on with my fellow psychiatrists, is unimpeded. The other is the boys' side, and it is interrupted every so often by a metal detector, which, in order to continue walking, they must pass through. They're not permitted to cross the line. Some boys walk alone or in pairs, headed to their jobs within the facility or to medical or legal appointments. Some walk in a line from their cell block to the prison schoolrooms. Visitors provide novelty, and as we pass, they turn their heads to watch us. They crane their necks. One cracks a quiet joke to the kid in line behind him, covers his mouth with his hand, smirks, punches his friend playfully on the shoulder. The friend laughs, watching the CO out of the corner of his eye, ready to become stone-faced should the CO turn to spot them. The boys wear matching baggy tan tops and bottoms that in another context I would have assumed to be scrubs. We go into one of the prison housing units, and a jocular guard greets us at the door. We are collectively introduced as psychiatrists from Yale, and he breaks into a wide smile. "This is jail, not Yale," he wisecracks. "I used to work at an adult facility, Maximum," the guard says. When the inmates would ask for special favors like books, we would say, "Where do you think you are, yo? This is jail, not Yale." All around us are the brown faces of teenage boys looking through their cell doors. Their expressions are solemn. They pay attention. "Oh man," the guard says with a chuckle. "I haven't thought about that for a long time. You all enjoy your visit." The CO takes us to a cell that is empty so that we can look inside it. The cell is tiny. We have to take turns walking inside because it cannot hold more than 2 of us at once. In the cell is a set of bunk beds, each with a 2-inch thick mattress. There is a small metal toilet, a small window in the metal door, a small amount of room to walk on the side of the bunk beds to the door or the toilet. There is nothing else. There is a school area, and there's a school area in the prison, and in the hallway, the students' work is taped up to the walls. There are pages describing what a stereotype is. There is a paper on Down syndrome. There is an art poster, a photograph of a wooden African mask. Because we are on a tour, we are being taken to see the kinds of programming that happens here. It is not nothing. I do not mean to say that it is nothing, but mostly the visit has been about the good the prison is doing. Here's the library. Here's the school. Here's the art poster. I am glad these things are here. I do not doubt their legitimacy, but it has felt disingenuous that we haven't really discussed the punishment that happens here, the punishment at the core of why this place exists. We attend a meeting with psychologists, teachers, social workers, correctional officers. We're given a chance to ask questions. What's the most severe punishment that can be leveraged against a boy held in this facility? I ask a psychologist. He can be sent to segregation, she says, noting that the practice of solitary confinement exists for incarcerated children just as it does for adults. For how long? I ask. Up to a year, she says. Take the developing brain of an adolescent, 14, 15, 16 years old. Put him in seclusion for a year. He touches no one, is touched by no one. He yells out, perhaps, or he stays silent, but he interacts with no one. His meals are pushed at him through a slot. We know that isolation changes and damages the adult brain. What about the effects of segregation on the still developing brain of a child? And a child who presumably has already lacked the foundation for good decision-making, has acted with extraordinary impulsivity, has perhaps enacted terrible trauma, and perhaps also endured terrible trauma. What then? The programming we've seen here, I ask the psychologist, the school, the library, the vocational skills, do the kids in segregation get that? In theory, yes, she says, but in practice, it's very hard to arrange. She says they have an hour of recreational time each day, during which they're also isolated from other inmates. One of the fellows in my group asks, do they have television in their cells in isolation? Do they have radios? Do they have books? She says there are no electronics. She says sometimes the mental health workers will give them books. I hear in my mind when the inmates would ask for special favors like books. Then what do they do if they don't have electronics or books, the fellow asks. His question hangs in the air. It is not answered. There is no answer. The American Academy of Child and Adolescent Psychiatry has been concerned enough about the answers to those questions that they've issued a policy statement on the solitary confinement of juvenile offenders. The potential psychiatric consequences of prolonged solitary confinement are well recognized and include depression, anxiety, and psychosis, they write. Due to their developmental vulnerability, juvenile offenders are at particular risk of such adverse reactions. Furthermore, they continue, the majority of suicides in juvenile correctional facilities occur when the individual is isolated or in solitary confinement. When we had passed the boys' cells, we passed one cell in which a boy was alone, standing on his toilet, neck craned, stretching his face toward the ceiling and talking out loud at full speed. I said nothing, assuming that the boy was mentally ill. After all, I frequently see patients who are actively hallucinating, who are in conversation with visions that no one else can see or voices that no one else can hear. Responding to internal stimuli is the notation I make in the chart to record that my patient remains tethered to those perceptual abnormalities of psychosis. Down the hallway, we then passed another boy in another cell in the exact same position, doing the exact same thing, at which point I knew that the conclusion I had come to was wrong. Though I've seen countless patients in the throes of psychosis, I have never seen the symptoms of mental illness manifest themselves identically in different people. Why are they standing on their toilets? I asked the CO. It's a big problem, he said. They figured out that they can talk to each other through the vents. It's loud in here, and also they get in trouble if they're shouting out their cell doors, so that's the only way they've got to talk to each other. They climb on their toilets to get up near the vents, and then they have whole conversations that way. This is the human pull for connection, the lengths of discomfort and risk and innovation that human beings will go to in order to reach out to another, to hear from another, to be heard by another. The image of it brings to mind the autobiographical words of Richard Wright. I would hurl words into this darkness and wait for an echo. And if the echo sounded, no matter how faintly, I would send other words to tell, to march, to fight, to create a sense of the hunger for life that gnaws in us all. So one of the things that I wanted to talk about today was just the question of what happens to the brain in solitary confinement. And in particular, to think about the adolescent brain in solitary confinement. So we know that the brain undergoes these critical periods of growth in adolescence, and as it's forming the permanent neurologic structures of adulthood. And we know that it draws upon the experiences and stimuli of adolescence, and that those things inform the brain's neural circuitry and have a really profound influence on the brain's development. So I started really thinking about how the sensory deprivation and the paucity of experience in solitary confinement would have lasting effects on the development of a child's brain, not just psychiatrically, which is well demonstrated, but neurologically as well. We know that psychosocial deprivation in childhood alters the brain structure at cellular and molecular levels. And we know that these changes then manifest themselves in functional ways, in behavioral ways, and in psychological impairments. And so, really it's important then to think about experience building brain circuitry, and then that circuitry reflecting the way that kids learn and develop and behave. So the logic of taking children who we know to have already been behaving in problematic ways if they've wound up in a detention facility to begin with, and then putting them in an environment potentially that further alters them neurologically and psychiatrically in their development, so that they are that their behavior becomes shaped by those experiences, seems to me deeply illogical. And of course, this extends to adults as well. One of the things that has felt so important to me to share from my research in writing Waiting for an Echo is that I had a misconception about our nation's prisons that I think many Americans do. I did not realize that 95% of the people that we send into correctional facilities return home to our communities. So with that number, that high a number, in addition to our charge just to be humane to people when we incarcerate them, if we only look at it from a selfish standpoint and think only about what we want for our communities, to put someone in a position where they are psychologically damaged and then bring them back to our communities doesn't serve any of us well. In thinking particularly about children, I looked at some of the robust literature on the neurodevelopment of children who were institutionally reared. So kids who were raised in orphanages, for example. And what we know is that those kids have lower IQs, that their brains show changes at molecular levels, that their telomeres are shorter than those of other children, and that their overall brain volume is reduced compared to kids who were not raised in institutions. The other thing that I found so interesting is that the brains of these kids show a precocious connectivity between the amygdala and the prefrontal cortex. And for those of you in fields other than medicine, we're really talking about a connection between the amygdala, the kind of impulsive, instinctive region, and the prefrontal cortex, which really plays a role in executive function and rational decision making. So a mature pattern seems like it could be a good thing, but in fact, researchers believe that this mature pattern of neural connection occurs earlier than it should because the kids have endured adversity without the protective buffering of a caregiver early in their lives. So we know that exposure to abuse and trauma can adversely affect kids' developmental trajectories. But one of the things that was interesting to me as well was just to think about the fact that the development of neural circuitry can also be adversely affected by the absence of experience or stimulation. And of course, that's what kids in solitary confinement are enduring, that this lack of experience can be particularly insidious because the brain is waiting for instructions to guide its assembly, and it fails to receive those. And that description of the brain awaiting instructions to guide assembly that it fails to receive was a really beautiful description that I found in the journal Neuroplasticity, just talking about what happens when kids are isolated. So going back to that early question about what can we do, I do not think that I anticipated when I began writing this book how much of the book really seemed to me to present opportunities for advocacy for those of us who are in the field of mental health. And I think also I began to feel a real sense of obligation to talk about what I was seeing and talk about it from the perspective of my expertise as a mental health clinician. I think that by and large, as a generalization in our society, we approach corrections as saying that whatever goes on behind those walls, we don't really want to think about. That we justify that by saying that if you've ended up in prison or in jail, you've done something bad. And so once you're there, you sort of deserve whatever happens to you. And that as a country, it really makes sense to consolidate our resources and use them on people who haven't done bad things. So why should we pay for college courses in prison when many of us struggle to pay the bills to send our own kids to college? But what I found, of course, which is true so often when we look more closely at complex issues, is that the issue is much more complicated than that and than it appears. And certainly for those of us with patients who are mentally ill, just the awareness that people wind up behind bars because of the symptoms of their illnesses should give us pause in the way that our correctional system conducts itself. Because if you're saying anything that happens to people behind bars is fine, because people deserve what they get because they've wound up there. It really says once people are there, everyone deserves to be treated the same, without acknowledging that some people are there because they're mentally ill. Some people are there, as we've just discussed, because of racial prejudice. Some people are there because of poverty. When you really look at pretrial detention and how very many people are held in our nation's jails simply because they cannot afford the amount of money to post bail. That simplistic view that all the people in jails and prisons are bad people who have done bad things begins to crumble and begins to fall away. And then we as a society have to ask ourselves if then we feel as though it's justified to treat people in the ways that prioritize suffering and vengeance that really infuse every level of our nation's correctional systems. And I think that question really came to me to be the central question of the book. We say we want safety and justice. We say those are the goals of our legal system. What we're really good at is suffering and vengeance. That we say we do these things in the name of safety and justice, but what we really what our practices really bring about is making the people who are held in our facilities suffer. And I would argue psychologically damaging even the mentally well people who are found therein. So I started thinking about, well, are there places that do this differently with different outcomes? And the answer that I found was yes, that there are countries around the world who have far better outcomes if you look at the measurements of safety and justice. But in order to accomplish those outcomes, decreased recidivism rates, increased ability for folks to reenter in the community, get jobs, start paying taxes, stay out of prisons, those methods are different than our methods, and they don't have the element of suffering and vengeance. So in order to bring about those changes, we really have to relinquish our desire to make people suffer. And that's a question that faces us all, I believe, in terms of what our priorities are for our legal system. So again, lots of talking. I'm going to pause there and see if there are other questions, which I'd be delighted to answer and make it more of a discussion at this point.
Thanks. And I have a couple of questions from the audience, and it's also, just kind of, it's hard to hear some of what you're describing because, we try not to think about it, but I'll defer to the questions in the audience. There's a question from the first part from Sam Bauer. Do you see any risk in paralleling mental health issues with bodily health issues in communication with the justice system? I worry that this narrative continues to paint those with mental health issues as fundamentally different, which may lead to continued interventions that do not acknowledge the humanity of individuals with those set of challenges. A similar question that I was curious about is, I think I know the answer, but when you're in SEG, you don't get treatment. your needs are completely, your mental health needs are completely forgotten. But if you had, hypertension, you're still going to get your medication. I just wonder if you could comment on that.
Yeah, I'm not sure. I want to make sure that I understand the first question. The idea that correlating psychiatric illness with other medical illnesses carries risk with it. Was that the question, Kevin? Yeah.
What's the risk in comparing those two in the justice system?
I mean, I think the risk is far. If the question posed is, do we risk seeing people as different by pathologizing them in that way? I think right now people with mental illness are really viewed as different. And I think one of the things that makes it easier for us to employ things like compassionate arrest is by saying, like, those people are other. Those people are different from me. They don't fully understand, or they don't respond in the same ways, or they're not able to control themselves. So I actually think, my second book was really, I think I have this thing in writing where I want to make people look where they don't want to look. So my first book was about dissecting a cadaver in medical school. My second book was about my experiences as a young clinician with severely mentally ill people, and now jails and prisons. And I think that the charge of my second book was really to try to chip away at people's ability to do this about people with severe mental illness, to say, but those people are different. Those people are not me. And I think that that's similar to the project of this book, which is to say, like, people who are in jails and prisons are really different to those of us who are outside, that there's a moral superiority that we have. In fact, there's a chapter in my book called Born on Third Base, which comes from, I'm from Indiana, good Midwestern saying about people who are advantaged and think themselves morally superior as a result is people say about them, he was born on third base and he thinks he hit a triple. And I think when there's that argument of moral superiority, that those of us who are not behind, who live our lives freely, are morally superior to those who are behind bars, really falls apart. And in that chapter, I talk about a dinner party I had with a group of very accomplished friends, very good people, members of the church softball team, people who prescribe medications, people who care for my children and help manage my finances, very, very dear friends of mine. And I was bumping up against this idea of people in prison are really different. And if you can't stand the time, don't do the crime. So, a bottle of wine or two into the dinner party, I had everybody at the table, 8 of us, 4 couples, go around and list all the crimes that we had committed. And it was a long page, and many that people continue to do. So some of them minor, I text and drive, I speed every day. Lots of them major. I was in college and we stole a bunch of street signs for a scavenger hunt. I was in college and I found a credit card in the copy machine at Staples and charged $2,000 worth of stuff on it before I threw it in the trash. I carried a firearm that wasn't registered to me across a college campus. I mailed marijuana edibles to a friend, and marijuana is not legal in my state or the state that I mailed them to. Interstate drug trafficking is a felony. None of my friends had ever suffered legal consequences for these actions. So our ability to extricate ourselves from legal repercussions is much different from our ability to commit the crimes that people are serving time for, that we ourselves have committed. Kevin, your question was about treatment in SAG. And the other thing that I think is so interesting in solitary confinement or in SAG is that the lens, again, really shifts in terms of how people are viewed. So the mantra tends to be, of course, they're monsters and animals. If they weren't monsters and animals, they wouldn't be here in this place. And so by definition, the people who are held in our supermax facilities are monstrous, are animals. Of course, first of all, there are plenty of racial overtones in the way that is discussed amongst staff in some of these facilities, but also it really changes the way that people are viewed and people are treated. So one of the foremost examples of this that I see when Kevin and I go into places like Northern Correctional Facility in Somers, Connecticut, is that self-injury is viewed in a completely different way than we would view it at IOL or at Butler Hospital in Rhode Island. That we view self-injury in our hospitals as a signal of dissociation, as a sign of past trauma, as a sign of lack of power. It really viewed in prison as pure sociopathy is the description I kept hearing. That this was seen only as a way of trying to get attention, of gaming the system, wanting to get sent out to the hospital. And so what I started to think about was, when are the ways that human beings are reduced to this kind of primitive behavior? And at the time that I was researching the book, I heard a report on NPR about the ending of the Cuban special status in the U.S., where then Cuban refugees were trying to come on these rafts and boats to America during the period of wet foot, dry foot. So they're trying to establish a dry foot on soil, because if they can step onto American land, then they are given status that they can stay. So the Coast Guard was intercepting these boats of people fleeing Cuba, and they said, you can't believe the things they're doing. They're drinking gasoline. They're cutting themselves. They're doing these egregious things to their own bodies so that we take them to the hospital. And I thought, this is what human beings do when we take away every ability they have to express themselves, when we fail to meet their most basic needs. And the only way they can try to act out of desperation is in these primitive, very upsetting ways. So the setting matters so much. And you're absolutely right, Kevin, that people that would receive intensive treatment were they in our hospitals receive little to no treatment when they're in solitary confinement.
This is a great talk, and I again, sobering. And I just want to point out some folks are leaving. So for those folks who are leaving, make sure you email. Thank you for coming. Thanks for attending. And some people do have meetings at 1 o'clock, but continuing at hhchealth.org in order to get credit for attending. I have a question for you from Sam Mashaw, and I'll come back to Dr. Weiss's question afterwards, who said that this talk has been really amazing. Thank you. And yes, it's very hard to hear. Have you found any language that's useful to help shift people's perspective away from revenge and punishment towards rehab and justice? Have you seen patients who developed mental health issues as a result of traumatic experiences in correctional facilities?
Yeah, so I certainly have, and I bet others of you have as well. I write about a patient in the book who was admitted to my care with suicidality shortly after his release from prison. And he talked about how he had chronically had auditory hallucinations, but that he'd gotten imprisoned because of also chronic drug use. He'd been in trouble with drug crimes. Once I started researching this book, I started asking my patients if they had served time in jail or prison before, and if they had, what that experience had been like for them. And he talked about a number of different things. One was he talked about how he had persistent nightmares. One of the nightmares he would wake up with his skin burning, and he talked about how when he was taken to shower, their handcuffs were cuffed. One handcuff was cuffed to the shower head so that they couldn't move, and that the water temperature would shift dramatically. Sometimes it would be ice cold, sometimes it would be searing hot, and people would actually be burned, but you couldn't get out of the water because you were cuffed to the shower head. His theory was that maybe the COs were controlling this. I didn't have evidence of that, but certainly there is evidence of correctional officers behaving in sadistic ways in all kinds of documented places. He also talked about being tear gassed and how he would have nightmares of being tear gassed, but he said the worst nightmare was waking up choking, tasting loaf. I had no idea what he was talking about. He said, "You've never heard of Nutriloaf?" And I said, I've never heard of that. Turns out that in our jails and prisons across the country, there's something that's called Nutriloaf, nutritional loaf. Management loaf is probably the most honest name for it. And this is a punitive food that is served that checks all the nutritional boxes that someone would need, but that is really disgusting by design. So the recipe varies across the country. In some facilities, they will just grind up all of the leftover meals into a puree, pour it into a loaf pan, cut it, and serve slices of that often to people who are in solitary confinement as their meal. Other places, there's a designated recipe for management loaf that ticks all the nutritional boxes. And in some places, it says things like margarine, oats, mechanically separated poultry and dairy blend. You know, these sort of really disgusting ideas of things that do tick nutritional boxes, so they can't be accused of not meeting the nutritional requirements of the detainees, but they're mixed together and served. And the trauma that really stayed with him was knowing that the only sustenance he had was eating that. And that, to me, really highlights this idea of suffering and vengeance, that we intend to degrade, that we intend for life within the prison system to be miserable. And the question was, did I find language to counteract that? And I did, and I found it in systems that were doing it really differently. So I went to Norway and Sweden to look at how prison is done differently there. And one of the primary things one of the primary philosophies is that your punishment is your loss of liberty, period. You don't get to sleep at home. You don't get to be with your children. You don't get to be with your friends. You're in prison. But beyond that, we're not going to punish you further than that. It's not our job to make you suffer beyond that. That in and of itself is punishment alone. They also do what's called a needs assessment on the front end. So they're trying to get at what was it that caused you to behave in criminogenic ways in the first place. So do you need substance abuse treatment? Then let's use your sentence to get your substance abuse under control. Do you need anger management classes? Do you need job skills? Do you need education? Do you need financial planning help? And all of these things that are targeted to use the period of time of incarceration to shore up those deficits in someone's life. And what Norway found is that they went from a recidivism rate around 70%, which is on a par of what ours is in our country, to 20%. But what that required was treating people like people, right? And treating people with humanity and dignity. They also changed the role of the correctional officer, so it was more akin to a social worker, that they, of course, were responsible for security, but they were also charged with getting to know the detainees and to talk with them and say, what was going on when you did this? How do you feel about having done it? What's going to prevent you from doing it when you leave here? None of the correctional officers in Halden Prison in Norway, where I visited, were armed, and 50% of them were female. And they this was a maximum security prison. The people who were there had committed murder, rape, violent crimes. They had never had an act of violence of a detainee against an officer. So I think the outcomes are much better, and we need to cite those outcomes over and over again. But what it really takes is kind of a question of the soul, of letting go of this idea that if someone has done something wrong, then they too must undergo a period of real suffering and vengeance.
That's great. Just so you know, we still have lots and lots of people on, and we don't often have lots of people on 5 minutes after the hour. So I think people are really enjoying this. We have several comments of people thanking you for the talk. I wanted to jump back to Dr. Weiss. She asked you to address private prisons and for-profit prisons, and I wonder if that might have to do with the soul of, our correctional system and things that are going wrong, and maybe part of the reason why it is so hard to make a shift. Do you have any comments about that?
Yeah, Kevin, so you, a little glitchy there for me for a second. Are you still seeing me loud and clear?
I'm sorry. Yeah, I lost you for a moment also, but we're back to where we should be.
Back on track. So I think I understood the question. The snippets that came through was a question about the privatization of prisons and commenting upon that. So great question. That's a really critical component of prison reform that we really have to take on in our country. And for those who aren't familiar with the idea, our country has made the decision to have many of our nation's correctional facilities privatized. This means that we have contracts with private companies that are for-profit organizations, and those companies and their shareholders benefit then from things that are really antithetical to our judicial aims. If our judicial aims are, hey, we want to bring down the number of people in prison, we want to arrest fewer people, we'd prefer fewer crimes to be committed, that's really different than corporations that depend upon beds in prisons being full, building new prisons, because so many people are being arrested and sentenced that we're building new prisons and we're hiring more people and employing and creating more jobs. So this narrative that it's financially lucrative to put people in jail and keep those beds full, keep them there for long periods of time, is really antithetical to our ideas about a just society, I believe. And we've seen some really sobering realities of this. So one is that even those arguments about financial gain. So for communities where prisons are built and jobs are created, unsurprisingly, those tend to be communities that are very different from the communities where from which the incarcerated people come. So prisons are built in rural, largely white areas. Often those jobs that are created benefit those communities. We know that our incarcerated population is predominantly people of color, many coming from urban environments. So the financial gains are often not benefiting the people who have been imprisoned in the first place. And this is a really critical moment in our time to also acknowledge that the census operates in this same way. So the census counts people in their place of residence. So if people are arrested in Hartford or New Haven and end up in Summers at one of the correctional facilities there, they're counted as residents of Summers. So the resources that are allocated by the census end up in those rural, predominantly white communities instead of the communities of origin of the people who are arrested in Hartford or New Haven. One other sobering fact that I learned when I was researching this was that and not to politicize the talk, but to share a fact, and that was that when President Trump was elected, the futures of private correctional companies really went up. So the assumption in the financial market was that more and more people were going to be imprisoned, and that there was going to be a boom in the prison industry when Trump was elected. So that's I'm glad that question was asked, and that's a really important piece of reform as we try to move forward.
Thank you. As we're winding down, if there's any other questions, please feel free to put them in the chat. One of our postdocs, Olivia, mentioned that waiting for an echo was influential in her dissertation. This was wonderful. She thanked you. Mm-hmm. There's several other people. Thank you. Yeah. Everyone's thanking you for doing.
Kevin, if you don't mind, Kevin and I see people when we do our competency evaluations who are in pretrial detention. So this means people who have not been found guilty of any crime. Many of the people that we see are innocent. They go home. Many of the people that we see have crimes that even if they were found guilty or even if they pled guilty might result in something other than incarceration. They might be sentenced to probation. They might be sentenced to they might be diverted to a program. They might have, by the time that Kevin and I have seen them, already spent 6 or 8 weeks or 12 weeks in jail, which might be the maximum for the crime that they committed. So pretrial detention is a really critical thing to understand, that we're holding people in jail and prison who've not been convicted of any crime. And in the era of COVID, this has taken on a really difficult turn. As Kevin will tell you, our ability to go into the prisons to perform perform competency evaluations has been severely diminished. We can occasionally do telehealth evaluations, but few and far between. And when a competency evaluation is ordered on someone who is presumed to be mentally ill, their case hits pause. And so they have to wait for their case to proceed until they've had a competency evaluation. So since March, there are people languishing in jail awaiting competency evaluations who perhaps never would have been found guilty, or perhaps the maximum sentence for their crime may have been 6 weeks in jail, 2 months in jail, and they've now been in jail for 6 months awaiting competency evaluation. So that's a really critical part. The pretrial detention piece and the requirement that people post money, cash bail money, is something that many of our fellow developed countries see as a real crime of ours. And that's another important issue as we're thinking about the finances. I think we're just about done. Are we done? Are we pretty much done, Kevin? If so, I'd just like to say thank you to people, unless there's one other burning something that I missed.
Nothing burning. I have questions for you that I'll ask you another time. They don't have to be during this.
So I'm happy to do that. Really want to say thank you I know that these virtual events are not a good substitute for the in-person events, and I wish that we could all stand around and talk further afterwards. But I really appreciate people joining, and certainly want to acknowledge that this is a time that is fraught for all of us, and I hope people are safe and well and families are safe and well. But thank you for hosting me.
And thanks again. This was a powerful, different sort of talk, so we really appreciate it. Thank you.
Thank you.
So this would conclude Grand Rounds. Folks who are looking for CME credit, please make sure you email continuinged@hhchealth.org. And that's it. Thank you so much. It was great.
You're welcome. Thanks, Kevin. I appreciate it. Thank you, Bill, for the tech support.
You're welcome. Nice meeting you.
Okay.
Bye.
Bye-bye.
Bye.
The host has left the conference. The conference is about to end. Your call will be disconnected.